Good afternoon to everyone again. I'm going to introduce you to the second SPIE invited lecturer, which is Dr. Katarina Svanberg. She's a professor at the Department of Oncology at Lund University in Sweden. She was appointed as a distinguished professor at the South China Normal University in Guangzhou. And since 2004, she was appointed as one of the directors in board of the SPIE. And in 2011, she was the president of the society. Right now, she works research in optical engineering. And her area of expertise is biological applications of spectroscopy. So thank you, Dr. Svanberg.
Thank you so much for this kind introduction and for inviting me here to Sao Carlos. It's really a great pleasure for me to be here. Actually, the first time in Brazil, I mean, I was in Sao Paulo, but only at the airport before, as I remember. And when I was very young, my father, who was from a little farm in the middle of Sweden, he was citing one of his friends in a neighbor farm. And we have to remember that these farms were so small. There were many kids on the farms, but they were maybe 10 acres or so. And he was citing his friend from the neighbor farm, telling that, oh, because he went out in the big world, and he was a sailor, so he went on the big boats. And one day he said, we came to Sao Paulo. So that was something that I remember from when I was a small kid. My father already at that time talked about Sao Paulo, and now I am even more than in Sao Paulo, I am in Sao Carlos. So I really appreciate this invitation here and to see all of you. And it's always so nice to speak to students. I mean, also the senior people, of course, are nice to speak to, but in particular to the students. And being an SPIE representative, we as a society, we are so keen about you, and we really appreciate you so much, and we look upon you as a future. When we are not there anymore to do some active research, we rely highly on you and your efforts. So I will today talk about therapy using laser spectroscopy. Tomorrow I will talk about how we can detect early cancer and also use some other techniques for detecting gas in hollow organs. And on, I think it's on Thursday, I will discuss also if or how we could bring these techniques to the third world. And I will give some examples from Africa, where I have been working also as a doctor. So as we heard, I am at Lund University, where I have been since many years, but now also since 1.5 years in Guangzhou in China. And that's, of course, a challenge. My hospital home is a traditional hospital. We have 2,000 beds, and it was built during 1960s. It's a comparatively dull building, but anyway, we have good healthcare there. We have specialized healthcare in many different areas. So it's a good place to work. And it has been a good place to do clinical research also. These days, we were discussing that over lunch. It turns out to be more and more difficult to do clinical trials, and that's a threat really for biomedical optics, I would say. So we have to do some joint efforts there to increase the possibilities or facilitate the possibilities for us to continue. My department, Department of Oncology, is actually the largest one, sadly, because cancer is increasing, and we are the unit that is the biggest at the hospital. We are connected through a bridge to the big building. This is Lund University headquarters, funded 1666, so it's one of the oldest universities in Northern Europe. We have 40,000 students. We have all faculties, And it's a very beautiful setting, and during this time of the year, the magnolias in front of the university are blooming. And every year, last day of this month of April, the rector has to give his address to the students, and if he or she does not refer to the magnolia, it's not a good speech. So if they are in buds, it means that the students are the buds for the future or whatever. So the rector, the vice chancellor, has to refer to these wonderful flowers which are outside his own building. This is a building in Guangzhou, Old Canton, South China Normal University. It's a new center called Center for Optical and Electromagnetic Research. We are on the 3rd floor here, and the building, when we came there 1.5 years, was a new building. As I say, the cement was not even dry yet, so it was empty house. 5 centers are now being built up in this building, and we are on, as I said, floor 3. So I hope in a while we can invite you to come there and to do nice research, and that has to be valid both for the students and for senior researchers. So we have also established some contacts with medical people already there. This is from the first affiliated hospital of Guangzhou Medical University, a very skilled professor there who is actually also the editor of a Canadian journal. So he is a very good point of collaboration for us. He's in lung diseases, lung cancer, which is very, very valid for China. The big threat in China is lung cancer, actually, because so many people are smoking. This is a group home led by Stefan Andersson Engels, started together. I started together with my husband, actually, Professor Svanberg. He is still around, and we try to supervise the students, and we also have some very good postdocs. And as you can see, it's an international group. We have had Chinese students since many years in the group, so that was quite natural for us, actually, to start collaboration or to continue collaboration with China. We started, the first visitor from China came already in 1980, so that was few years after the Cultural Revolution. As I said, we started also 1982 to do biomedical optics research at Lund University. And the first PDT session in Scandinavia was actually performed a few years later. And the light source we had was absolutely not a clinical laser. It was an argon-pumped dye laser in physics department here, giving light here in the red region. And so we had to bring the patients over to physics department. We have to remember that at that time, the lasers were not there. There were the copper vapor laser, and it was this type of laser, which I said was just another research tool, and that was mainly for basic research. We established something we call Lund University Medical Laser Center, 1991, and that was based on the collaboration of 19 clinics and departments at the university. And we are nicely located within less than 1 kilometer. We have the hospital, physics department, and the biomedical center. So we have a good logistics there to do the research, which we have been utilizing, actually. And this is a sign of the university. The lion has a sword, and this sword is meant to defend us from the Danish people. So that's sort of politically not so interesting these days, but when the university was formed or was founded, it was actually to Swedenize this area, which we just had conquered from Denmark. So the peace was 1658, and the university was formed, as you heard, a few years later. At Lund University Medical Laser Center, we have a lot of activity within this field. We do tissue optics, and that is mainly Stefan Andersson Engels, who has built up this around photon migration. Time-resolved spectroscopy is something we deal with, laser-induced fluorescence, Point monitoring imaging, I will go through that tomorrow. Autofluorescence detection, tumor enhanced detection using also tumor seeking agents. We have heard about the tumor sensitizing agents this morning, and these are exactly the same for detecting tumors. We have developed a new technique which we call gas in scattering media absorption spectroscopy for investigating gas in, as I said, hollow organs like in the sinuses or in the lungs of prematurely born babies. We do photodynamic therapy, laser Doppler imaging to measure or to monitor the effect of PDT, to see the perfusion in the tissue. We have tested many new sensitizing agents. We had a brilliant talk this morning about all these different sensitizing agents. And we have had regular interaction with patients with various malignant tumors. And of course, we also do some studies on tumor models. During these years, we have produced 17 doctoral theses, and they are all in the field of interdisciplinary research. So all of them have a technical, physical, chemical background, but they also have a medical background. That's the reason why we are so eager to collaborate cross disciplines, and I think that's one of the key in biomedical optics. We need this interaction, actually. We have performed several clinical trials out over Europe mainly, but also, as I said, we have gone to Africa. We have been in Malaysia and also in China. And as I said, the key is collaboration over the different scientific fields. And I show here one example where we also interact with industry, because I think that's one important aspect. To try to get these techniques out to the patients, we need the industrial collaboration. But we also need, at our own hospitals, to work cross professions. And I have learned during the years that it's very, very important to include the nurses in the clinical trials, because the nurses are the ones that are closely related to the patients, sometimes much more than the doctors, actually. So if we have the nurses on our side, this is one key to be successful, I believe. I am an oncologist, so I work with tumors, with cancer. These are numbers from Sweden. Every 15 minutes in Sweden, we have one cancer case diagnosed. The highest incidence we have in the big cities. In the rural areas, the incidence is much lower. So that tells us something from the epidemiological point of view, that it's more dangerous to live in a big city. And there are many reasons for that, of course. The numbers for the US are approximately the same, but of course multiplied by the population. And generally speaking, 1/3 of us will die from cancer in the Western world. Only cardiovascular disease causes more deaths. We have the most common cancers listed here. This is for the Western world again. And you see lung for men, breast for women, and prostate. These are, of course, sort of the same kind of cancer related to our enzymes or how we are constructed, and that's something that is interesting to see. For example, with prostate, which is so common in the Western world, and in Asia, for example, it's much less evident. But if a young Japanese moves to United States, he gains the same kind of risk to get prostate cancer as if he was an American young person being brought up in America. So it really has to do with some environmental factors. Skin cancer is an increasing problem with increasing cost, I write there. And that is really true. So if skin was included in this list, it should come on the 2nd or 3rd place. So that's a cancer that is not all the time registered. So that's the reason why we cannot count it into this list. This is a corresponding list for China, and you see it's quite different here. You see lung liver, stomach, esophageal, colorectal, pancreas, and breast cancer comes very low number here, as well as prostate for men. And that's interesting to see that it really differs a lot. In Japan, the cancer incidence or the deaths from cancer is higher than for heart disease. So that might also have to do with I think with food, for example. It's very important what we eat. And this is the background of cancer. Tobacco smoking, of course, is not healthy, that we know. Food, approximately 1/3 of the cases is related to what we eat. Sexual habits, this is important, for example, for prostate cancer. We have lower prostate cancer incidence in Lund as compared to Copenhagen, and that's only a little strait, a little piece of water in between. And they have approximately 3 times higher prostate cancer incidence in Copenhagen than we have in Lund. So that tells again something. UV radiation, that is of course, all of the UV radiation is associated with skin cancer development. We heard about light interaction from Bruce Stromberg this morning, and photonics in interplay with biological tissue is light interacting with biological tissue. And absorption, of course, is a main phenomenon that appears there, and it causes heat, of course, but it also can generate fluorescence, light or laser-induced fluorescence. We can use it for PDT, for photochemistry. Some light is scattered, we heard about that this morning, or transmitted through the tissue, or we can measure moving particles by looking at the Doppler imaging, sending in light and look at the frequency shifted light that comes back, and by that calculate the movement of the particles that are in the blood or in the lymph vessels. We have something which we call the tissue optical window, and that's where we are comparatively transparent. This is a logarithmic scale here of the absorption. We have the wavelengths on this scale here, and we see that it's not until in the red part of the wavelengths region that we are transparent here, and that's when blood has lost its grip and is not absorbing that much anymore. And blood has its special peaks here, as we see. And that's, for example, what the ophthalmologists were using when they used the ruby laser. Then they used the absorption of blood as the interaction. And then we have the water coming up here towards the infrared region. So it's approximately after blood has not so high absorption and before water starts to absorb heavily that we have the tissue optical window. We have the melanin, which is absorbing more in the UV region due to the fact that it should shield us off from the UV illumination, and not so much in the infrared region. Clinically, we can apply light in many different applications. We can do it endoscopically because we can take the light through fibers, and that is with laser light. We can never use the light-emitting diodes, for example, to illuminate down in the hollow organs. There we need the laser. But for the surface detection or treatment, we can well use other light sources, like for the cervix, the ENT area, which we heard from Colin Hopper here, and of course the skin. Skin cancer, as I said, is increasing heavily, and it is a cancer type that increases most in the world where we have skin like myself or even brighter. And you also here in Brazil, of course, have a mixture of skin, and that is not so well suited for the good weather you have here. I have read some studies, and these are quite interesting to read, because what we see here is, this is a Swedish study, where they say that approximately 2% of the tumors that were surgically excised were cancers, malignant tumors in the skin. The rest were some kind of benign lesions, but that they could not be separated out from the malignant ones. And that is, of course, something that we have to take into account when we do this research in biomedical optics, that there is really a clinical challenge for us to do better detection, better diagnosis, and also, of course, treatment, more minimal invasive treatment. A classical patient I get in my clinic, a person who has a lot of sun-damaged skin, but also, of course, some lesions, some inflammation, but also some cancers among all these. And here it's very hard to say what is what. And this is what we say is a field cancerization, but we don't know exactly what to treat here. And here photodynamic therapy is ideal, and also the detection with the fluorescence is good to use here. And we would like to have some diagnostics which is not related to punch biopsies by drilling a little knife into the skin here and send it off for histopathology. Rather, a little tool, maybe this little miniature thing here, to put on the skin and give us some indication on what the patient has. Or this patient, an elderly gentleman who has been out in the sun a lot, maybe he's a farmer, I don't remember, but anyway, he has a lot of skin lesions, and we cannot say for sure which is which here. The tumor borders, another clinical challenge. Where are the borders? How does the tumor stretch out in the surrounding area? And we had a patient here coming with a known tumor sitting under his eye here. And this was biopsy. We had a biopsy on this, so we did know it was a nodular basal cell carcinoma, but we did put the scan over here, and we could have a good indication that that was also some type of tumor, most probably the same as here, but superficially growing. And instead of only treating this one, we treated the whole area, and by that we made certain that the patient would not have a recurrent tumor. And in this case, we did photodynamic therapy with our laser on this area. So photodynamic therapy, as we have heard from Dr. Allison, relies on three components: the sensitizing agent, light of appropriate wavelengths, and oxygen, to cause primary effects, which is a direct cell toxicity, but also secondary effects with a vessel damage and apoptosis induction. We can also look upon it like this, or we can see it from the type. We are dealing with type 1 reaction or type 2 reaction. Type 2 reaction is the one that describes the production of singlet oxygen, and this is the type 1 is the production of the free radicals. But it all relies on the same three components. And the physics behind this, we have a sensitizing agent here. We send in light. This is protoporphyrin in this case, 635 nanometer. The protoporphyrin molecule is excited to a higher energy level, but nothing in nature would like to stay at a higher energy, so it falls down, and in this, the excess energy is given over to the triplet state oxygen, which is transformed into singlet oxygen. So it's really a complicated way to produce singlet state oxygen here, which is very cell toxic. And this is like when they play ball. They throw one steel ball to the other, and the energy is transferred over to the other ball, which starts to run. I talked about the light sources, and this is our first clinical light source. It's a frequency doubled, intracavity frequency doubled YAG laser at the bottom here. It sends out 532 nanometer, and this light, the green light, is pumping a tunable dye laser on top here. And we get out, in this case, 635 nanometer to treat ALA, protoporphyrin here in this case. And after a while, we were able to buy actually BioLitec's first clinical adopted diode laser, which went from 300 kilogram laser to this 15 kilogram, which was, of course, an opening to bring it to different clinics, which was not so easy with a very, very big and heavy tool. These days, for skin cancer, we use LEDs, which are, of course, practical, but as I said, they cannot be used for everything, but for skin cancer, for example, they are ideal, and we have this from company in Norway sending out light at 6:35. And I would say that treating skin cancer with ALA, it's appropriate to be at 635 nanometer, because when you slide off the peak, you lose approximately 30% of the efficacy of the light, but still, of course, it excites the protoporphyrin. There are various modes for light delivery. Superficially, perpendicular, just shine the light onto the tissue. That's the most easy, simple way of delivering it. The tumor bed illumination, I think, has been too little utilized. And that is something that I would like to propose more, because when the surgeon take away the tumor, there might be remaining cells, malignant cells. And we have done some clinical trial together with a urologist in Louvain at St. Peter Hospital, where she took away by electrical coagulation the papillary tumors in the bladder, and then we did shine light onto the tumor bed. The patients had ALA before, and a follow-up showed really that the recurrence rate was less evident than if we didn't do that. You can also, as I said, take it down to different endoscopes as a fiber goes into the biopsy channel, but you can also use it interstitially, and we heard about that, when we take the fibers directly into the tumor and let the light shine from inside. This you saw this morning, and the list goes from 630, which is photophrin, hematoporphyrin derivative. That's one of the absorption peaks here, down to Tucard, which is a bacterial chlorophyll, 760 nanometer, and that means in depth of penetration, approximately double penetration. So if we have 2 to 3 millimeter here, we have approximately 6 to 7 millimeters penetration down there at 760. And we have to be very aware of this. And when we first saw, for example, data from Japan, where they were treated with hematoporphyrin, lung tumors which were 2 centimeters in diameter and the volume that big, and they said they had complete response. I'm quite sure that they also induced some hyperthermia. And we have also shown that hyperthermia together with PDT is a brilliant treatment modality. But if we should do only PDT, we have to be aware of the fact that we can also heat the tissue. And for skin, for example, we have a number of 110, 120 milliwatt per square centimeter, which is the highest you can go not to induce heat. And why don't you want to induce heat in the skin tumor? That's because the cosmetics result goes down if you induce heat. And if you keep it only to the photodynamic therapy, you have a much better cosmetic result. The sensitizer Tucard has a different kind of mechanism for killing off the tumor. This is related to the vascular occlusion. So we see here one example from the company Steba Biotech, where they do the treatment at the same time as they inject the sensitizing agent. So this is a different modality of PDT as compared to all the other sensitizing agents. And you see the vessel here is closing during the treatment, and that's the mechanism with the vascular active sensitizing agents. So as we heard this morning, every sensitizing agent have its own mechanism, and in particular the Tucard is quite different. There has been a debate whether photodynamic therapy is selective or not. This is one of our first patients treated with hematoporphyrin, and we can really here see that there is a selectivity, because the tumor was treated with a top hat distributed light over the whole area. We had a micro lens, so it was really a top hat distributed light delivered to this tumor. But still we see only necrosis in the area where we have tumor, and the normal skin here is not affected, does not go necrotic. So this is really a good example of tumor selectivity. What we also know is that it can be repeated. Me being a radiologist treating cancer with ionizing radiation, I know exactly how what dose I can deliver to the patients, where I have to stop, otherwise I destroy more than I cure. But with PDT, we can repeat the treatment because we have no accumulated toxicity. We also have a comparatively fast healing with minimal scarring, depending on how we deliver the PDT, of course. Organ function is retained. If we treat, for example, the large intestine or some area which has elasticity, it comes back after the treatment. We know that systemically given, many of the sensitizing agents cause skin sensitization. I will only tell we have performed in Lund up to date approximately 3,000 skin malignancies, and we have done some phase 3 clinical trials where we compared PDT with other modalities to be able to introduce this as conventional treatment. So every Wednesday at my hospital we do PDT treatment now of skin malignancies. This is just to show you that there is a skin sensitization, and this is a famous picture of Meyer Betz when he was injecting himself with some kind of HPD, hematoporphyrin derivative, and he really had a severe skin sensitization or skin reaction, which of course is not persistent, it goes back. For ALA, we don't have this problem because we do it directly. We do it topically to the tumor. We apply, for skin cancer, we apply it in a cream, but we can also have the patients drink it. We have done that for tumor identification on the vocal cord. We can inject it also. And it has some time for building up the protoporphyrin, which is an active component. And we can utilize it both for diagnostics, to detecting tumors, and for treatment. And that's the good thing with ALA, that it really works both ways. And this is the chemistry behind. It's glycine and succinyl coenzyme, which is condensed to ALA, and then it goes through all these steps all the way to protoporphyrin 9, and it stops here in malignant and pre-malignant tissue to a certain degree, because the ferrochelatase is less evident in tumor tissue than in normal tissue. The ferrochelatase is the enzyme that brings in the iron in the middle here. So protoporphyrin is very similar to HAM, but it doesn't have the iron in the middle. This is not a sensitizing agent. This is not active. It has to be with an empty space there. It's very similar to chlorophyll. We have the chlorophyll molecule here. We have HAM here. And you see both chlorophyll and HAM, they have each of them a metal inside here. And this is protoporphyrin before it goes to HAM. And this happens both in the mitochondria, the first steps in the mitochondria, and then we have it also in the cytoplasm. So these steps are in the cell. And we can see it like this. The principle for topical application, we apply it to the skin, it diffuses through, and the metabolistically generated protoporphyrin 9 appears when it has gone through the skin, and utilizing also, as I said, the oxygen for the photodynamic effect. We have measured the mechanisms of ALA-PDT. And for example, we have used the infrared imaging. We see here the treatment fiber, the laser fiber here. The treatment area is here. We have a little scale here. And what we see here is that all the tumor area is filled with blood, but we also see that the area around here, the vessels are opening up. So it sends in blood to the area. So it's a little bit like being bit by a wasp. It's an inflammatory immediate response. And we see that also in laser Doppler imaging perfusion here. We see the treatment area, the yellow, red here shows high perfusion, but we also see it in the surrounding area. So the whole area is really filled with new blood coming there. This is the fluorescence when we do the scan from outside the tumor to the center of the tumor. We see how protoporphyrin is built up, but we also see after PDT that we bleach away the protoporphyrin. So protoporphyrin is heavily bleached by the laser. So it's, if we would like to, it's metabolized by the laser light. So this is, of course, a parameter for dosimetry calculation, the bleaching of the drug, which we have been also used for FOSCAN. Again, one of my first patients, she was treated in 1991. This patient, this is actually a nodular basal cell carcinoma, but it reacted quite nicely, and as you see, we had by histopathology only some elastosis afterwards and never any recurrent tumor. This is a T-cell lymphoma, a little bit more difficult tumor to treat, but again, good result. Or this squamous cell carcinoma, which is growing almost in a circumference at the finger here. And I'm not sure if there is any other good treatment modality for this type of tumor, because it is complicated growing, but we see that we could nicely heal it with ALA. This was a squamous cell carcinoma. And the indication for PDT we have listed here. We think that large lesions, more than 4 centimeters in diameter, are ideal. Multiple lesions, lesions which are located on sensitive area, like the face or pretibial area, and where we have underlying cartilage, like the ear, nose. Because if we, for example, do radiation therapy, we will melt the cartilage, and the form of the ear, for example, nose, will look very different afterwards. We have an excellent cosmetic outcome. As I said, we have short healing time, and it's comparable in the response to conventional techniques. This is an example of a patient with real multiple basal cell carcinoma here. He had a lot of surgery, and you see all these scars on his back here. And of course, in this case, it should never be, if we can avoid surgery, it's much better to take photodynamic therapy, for example. We have done, as I said, randomized studies. This is one that we performed 2000, and it was in between cryosurgery and ALA-induced PDT. We had 85 patients included. No morphia growing basal cell carcinomas were included. And the clinical outcome was for thin tumors, less than 3 millimeters in depth. We had 90% complete response. For the thicker tumors, also good response, but there we usually had to give them 2 treatment sessions. And what came out was that cosmetic outcome was much more favorable for ALA-PDT as compared to cryosurgery, and the healing time also much shorter. But there is, of course, a limitation, and that's a penetration into the tissue. We have millimeters for superficial illumination. To get deeper, we need to do the delivery in another way, and that's where the interstitial PDT comes in, as the light is really exponentially declining or decreasing when it goes into the tissue. So we need to be smarter than that. First clinical trial we did was in collaboration with Latvian scientists and doctors. So we brought our instrumentation over the Baltic Sea to Latvian Oncology Center and put up our treatment here. This was not fully interstitial. We did put the fibers in direct contact with the skin and had the ballistic light going into the tissue, and we treated 10 patients, 12 BCC lesions, and we had a good outcome. Actually, 92% of the patients were healed. Too few patients, of course, to draw too many conclusions. We did fluorescence in combination with treatment, and this is how a session could look like. And the lady here, for example, with a matrice on her back and the light shining. We took it over to Lund, and here I was more brave. I did put the fibers directly into the tumor of this lady, and as you see, we are sitting chatting here to each other, so it didn't hurt. for her, as she told me. What we are now aiming at is to take this technique to prostate recurrent cancer after radiation therapy. Because the alternative for these patients is hormone therapy. And we know that the hormones are more toxic than we anticipated when we first started this treatment maybe 10, 12 years ago. So we are quite sure if we could be successful here, we can offer the men a very good treatment for their recurrent tumor. And that's what we really hope that we will be able to show. This is how we first started with building up our instrumentation, both for treatment and for measurement, and it's related on many different fibers. We started with 6 fibers. Now we are up to 18 fibers. This is how the instrumentation looks like in the industrial prototype here, with 18 treatment and diagnostic fibers. This is built for Foscan. It has a real-time monitoring of the light transmission of the sensitizer content based on the fluorescence, which of course is not exactly the same, but it gives us an indication, and the tissue oxygen. And it gives us, by looking at all these parameters here, we can have an online feedback therapy based on the light transmission. And this is how the principle for the light is. We send in light through one fiber, and we measure with the other fiber. So we measure all the light, the fluence in the whole area, and that means also in the whole volume. And we see how the intensity during the treatment goes down, and that is different for different fibers, so we could easily adjust for the fiber that doesn't go up to the threshold dose that we are aiming at. And as I said, we are also monitoring the sensitizing agent, and we see the same here. We see how the sensitizing agent is photo-bleached at the end of the treatment. And from the oxygen point of view, we measure the oxygenated hemoglobin and the non-oxygenated. This is, we heard about the pulse oximeter this morning, and that's what they use is a isobestic point here, where the two kinds of hemoglobin are absorbing the same. And this is the saturation that we have measured during the treatment. So we see that there is also consumption of oxygen in the treatment. The iDose, they call it the iDose system here, works like this. We build up an ultrasound image of the prostate, so we generate the 3D model. We calculate the optimal fiber position based on the tissue optics evaluation, the scattering and the absorption, and we do the dose planning. And we start the treatment here and interactively in sequences measure the parameters that I explained. So we have sort of a possibility here to adjust the light so it comes up to the threshold dose that we have decided in advance. So this is again how it works with the fibers inserted, taken into account the organ at risk. That's the rectal wall, the upper and lower sphincter, and the urethra. So the fibers are positioned to give the best optimal light distribution and at the same time save the organs at risk. And this is how it looks like when time is going. So this is instrumentation. It is now built for another sensitizing agent, and we have FDA approval to start 2 clinical trials, and we are just now in the process of recruiting money for the clinical trial. So just some clinical pictures here. We have done 4 patients so far in a pilot study. We do the 3D mapping. We insert the fibers. The needles are placed here in the matrix, which is exactly the same as they use for brachytherapy. We have the intrarectal ultrasound probe here to build up our 3D model of prostate. Like we see here, these are the white spots here are the fibers inserted, so we can control that they are in the right position. And this is how it looks like when all 18 fibers are delivering the light. Some dose map to tell us what we really did here. The orange, for example, is untreated prostate. We have the gray, which is treated prostate tissue here. The black is untreated surrounding tissue. The white is treated surrounding tissue where, for example, the urethra. Light blue, untreated rectum. We have the rectal wall here, and we know that the rectum is the risk organ. If we do radiation therapy, for example, 15% of our patients have a bleeding proctitis afterwards, which is quite annoying, in particular for elderly people. And we also have untreated, you see all these organs that we have different colors, and we can see the dosimetry, the result here. And how should we look at this? This is the threshold dose for each tissue in percentage. This is the prostate, so we see when the treatment is over, we have treated approximately 100% of prostate. That's also what we see here. We see, for example, the rectum, this magenta colored here, that we have a little, only approximately 5% of the light was delivered to the rectal wall. We have the urethra, is the yellow one. This is not very dangerous because it recovers fine after the treatment. And we have the same here with the prostate in the 4 patients. We see that it comes up to almost 100%. The urethra less, but in particular these which are the organs at risk, they get lower treatment dose, and that was also what we were aiming at. Some maps where we can see at the histopathology. This is the sensitizing agent, how it's the red is higher concentration, blue is the lowest, and we also have the histopathology here corresponding to the maps here, and we see that it's quite nice necrotic formation where we have the high intensity. And as I said, the fibers were were inserted, so we had the threshold dose reached in all the tumor or all the glandular tissue, because this is a tumor that we anticipate is spread when it's a recurrent tumor, is spread in the whole prostate volume. That's the reason why PDT in this case we believe is better than, for example, the hyperthermia which we were discussing yesterday. Again, a dose map over the fluorescence of the sensitizing agent Foscan when we started time 0 here, and after some different time frame here which we can see is when time is over, we have almost no sensitizing agent still there. The aim, of course, is to try to, as much as possible, combine detection, optical detection, and treatment. And that's what we have done here in one case at ENT department with a very thin vocal cord cancer. It could not be treated with thermal laser because it had the growth over the commissure here. So it was not only located on one side, it came over to the other side. So we did the imaging, and then after that we treated according to our image map there. Other challenging indications for PDT, esophagus, of course, Barrett's esophagus for detection, and of course for treatment when we have signs of development of adenocarcinoma, or pancreatic cancer, which is a disease with very poor prognosis, usually very late diagnosis, and only up to 15% are operable at diagnosis. So here the aim is to shrink the tumor and make the patient in a status where surgery could be performed. Or maybe in the urinary bladder, I said before that it might be a good way of illuminating the tumor bed. If it's good for tumor treatment in the urinary bladder is not quite clear, because what happens or what has happened in the clinical trials that were performed is that we have a shrinkage of the bladder, which means that the patients gets into an urgency status afterwards, that they cannot feel comfortable with the bladder because it's sending it's sending out reflexes that it wants to be emptied too often. So with this, I think I have went through a lot of aspects of PDT, and the conclusion, of course, is that we should not use PDT on cases where we are not quite sure that it works. We know after all these clinical trials that we have done that for superficial skin tumors, it's perfect. We know that if we have thicker tumors, we have to be aware of recurrent tumor. We have to retreat. If we do curettage, for example, take away the bulk of the tumor, we end up with less good cosmetic result. So we have learned a lot during these 30 years we have been working with the technique, but we still believe that we are in a position that we have developed a technique that has potential to be accepted, and we all need to work in that direction, I think. Thank you.
Thanks very much for the talk. Somewhere you mentioned that with PDT, we don't have the effect of accumulated toxicity. I wanted to know if there has been studies to show that there is no late toxicity associated with PDT, like fibrosis or late damages to the vasculature.
Fibrosis development? I mean,
right, yeah, later.
Yeah, okay. As I said, we have to be very aware of delivering PDT alone, so we don't mix, for example, with hyperthermia, because then we develop fibrosis or bad scarring. So PDT itself, I think, has a very good potential of not building up fibrosis.
What about the vasculature, damage to the vasculature, like long-term?
Vasculature?
Damage?
Yeah, depending on what sensitizer you are using. So, I mean, some of the sensitizing agents, they aim at the vasculature. And there, of course, the vasculature is destroyed. And I also believe that when you deliver PDT and the vessels are blocked as a secondary effect, then, of course, the vessels are occluded. And they, but that's not the usually with the sensitizing agents that I discussed, it's not the usual immediate response. On the contrary, you saw that I showed an opening of the vessels. So they are reacting the other way around. They open up rather than occlude. That was for ALA-induced protoporphyrin. And I think it's exactly the same for hematoporphyrin.
Any more questions? No? Okay, so thank you very much, Dr. Svanberg.